Please. Okay, so I'm Megan White. I'm the president of the Australia Orthopaedic Nurses Association in New South Wales branch. So today I'll be talking about orthopaedic wounds. So when looking after the orthopaedic patients, a common challenge is optimising the wound management. Whether a patient is an emergency or an elective admission, orthopaedic nurses are faced with very similar and challenging um, concerns, especially when it comes to wound management. It's not always the latest and greatest products that will assist in healing orthopaedic wounds either. Wound management needs to be tailored individually with client-centered goals as one of the principles of wound management. So when we look at surgical wounds, the first aim of a surgical wound is to heal by primary intention. Secondly, you've got secondary intent or your delayed primary intention. So these are the three different areas that we'll discuss individually. Some of the perioperative strategies to improve wound healing is a lot around patient education. So really understanding your patient's medical and surgical needs as well as their social history. Looking at how prepared the skin is. There used to be a lot of us that would be clipping the skin, but now we've moved away from that. Optimizing the oxygen levels, making sure our patients are well hydrated, making sure that our patients are comfortable with their pain management, looking at minimizing the exposure of the extremities, especially during theatre, and also optimizing their comorbidities. So if your patients are diabetic, optimizing this before they have their surgery. So when we talk about surgical wounds, there's 4 different classifications. So you've got your clean, which is your elective. So this might be your total hip or your total knee replacements or arthroplasties. With your then you've got your clean or your contaminated, which is your emergency, your fractured knots, or you've got contaminated, which can be a non-purulent wound, or dirty or infected, where you've got that real purulent discharge. Most surgical wounds go on to heal in the normal pathway. So they go through the inflammation, proliferation, epithelialization, and then they mature. Emergency wounds generally have a higher incidence of dehiscence or complications. When we talk about the management of surgical wounds, wound cleansing is probably the most important skill that orthopaedic nurses will do. So when we're looking at wound cleansing, it's choosing the right product, whether it be tap water, normal saline, or some of your other products, for example, your macrodacins or your pontosans. Also looking at the homeostasis of the wound as well. Looking at what type of wound closure. Some literature will support the use of staples or clips, whilst others will use monocryl. Look at the drainage around the wound, and then it's your choice of dressing as well, which I'll talk about later, and then monitoring for your complications. So when we look at wound closure, especially with a surgical wound, we're approximating the edges for rapid healing and looking at minimal scarring. There's no foreign bodies, or if there is, that they can set up the inflammatory response, and that's where the wound will stay in that inflammatory phase. So any type of staple, clip, sutures, we want to remove them as soon as the wound is strong enough to be able to remain intact without their support. Often if staples or clips are left in too long, you'll start to see a bit of a reaction with the skin or erythema around the site. Removal time generally is in accordance with individual surgeons, but usually you look at 5 days for facial or head wounds, 7 to 10 days for abdominal, and 10 to 14 for major orthopaedic approaches. Also maintaining that aseptic technique or a no-touch technique. So when you look at the method of primary wound closure, with your sutures, it's how tight the sutures are, the size of the tissue. The distance between the sutures can also affect your wound healing. whether it's continuous versus interrupted. And then you've got your examples there of your clips, your staples, or skin tapes. And another common one is your glues, which is gaining popularity. So when looking at primary intention, it is the healing of a wound where wound edges heal directly and they're touching each other. Again, you get that small line. The goal is to minimize the need for granulation tissue, and this way you hold the wound edges tightly together and scarring is minimized. So here's examples of your primary intention using your monocryls and some common dressings that we use in our practice. The dressings for these types of wound need to absorb a small amount of anticipated exudate. Waterproof is ideal so that we can encourage our patients with all their daily activities and encourage them to actively participate in physiotherapy. Think about the edema management as well and the patient comfort. And these types of dressings tend to be left alone. Majority of them are on for a week or a leak. But again, keeping them covered. Some facilities will reduce the dressings at 2 days and leave them exposed. Others will keep them longer. Again, there's not a lot of literature to support either side. When you're assessing the surgical site, just looking at evaluating the primary dressing. So as we can see here, the dressing's done its job, so it's time to change. Looking at the epithelial resurfacing, again, looking at the wound closure. Generally, around 5 to 9 days after the wound, you can get a healing ridge. And this way you get that infiltration beneath the skin. And it extends about 1 centimetre each side of the wound. So again, the surgical dressing for at least the first 48 hours. What dressing? So again, looking at the patient, understanding what medications they're on. So when we talk about medications, are they on a blood thinner that's going to increase the amount of exudate? Do they have fragile skin where you may need to pick more of a silicone-based dressing? So the dressing, you just want to promote healing. You want to keep the wound rehydrated. Balance the moisture. You don't want to dry the wound out, but then you don't want to make the wound too moist that you end up with a macerated surgical site. Something that will manage the exudate. So if they are on a blood thinners, you're going to need a lot more of an absorbent dressing. Microbial balance. Again, that's where a good waterproof dressing assists in the microbial balance. Odor control tends not to be an issue with a surgical wound. Wound, again, protecting the wound and what's most economic for the facility as well. Some of the complications of surgical dressing can be blistering. So this can be either from where a dressing is applied under tension, and that's where you'll get friction between the layer of the dressing and the top layer of skin, or it may be from edema where you'll get friction between the top 2 layers. So between the epidermis and the dermis, you'll get friction between that, which will result in blistering. So this is an example of 2 areas where we've got large blistering. So in these circumstances, you can see how this dressing here, the blisters were broken. Again, to get rid of the fluid in the blisters. And this one here, we left these blisters intact, but we ended up releasing some of the fluid around this blister. So we needed to control the exudate so that the edema, so that these blisters wouldn't refill. But again, we wanted to make sure, because these were both orthopedic surgeries with hardware, we didn't want to contaminate or infect the areas. So for example, with these types of dressings, this is where we would put a silicone on and really treat it like a skin graft and wrap that up, and we wouldn't need to look at it for about 5 to 7 days. This way then our patients can keep going with their physiotherapy as well. We used to leave our blisters intact, and again, the literature is very divided about what the right approach is. But we would find then that 2 to 3 weeks down the track, these fluid would still be filled, but they'd be more like a gel. So we tend to just either de-roof or release the fluid around the 2-day mark. Here's some more examples. So here's another blister that we had just released the fluid. Again, you could tell quite a lot of bruising, a lot of edema around the area. So just by releasing that fluid, we put a silicone dressing over that, and then that way we were able to keep that epidermal flap intact. Another blister, which again we released. And here's one 5 days on, where you can see how you've got really good epithelial growth along where we had de-roofed that blister. Obviously, we don't make a general one-size-fits-all for our patients. We do have to look at what their comorbidities and their medical history is, because obviously if you're a diabetic patient, we would be a lot more conservative. However, if you're quite a healthy patient and or the fluid's putting a lot of pressure on the surrounding tissue, then that's when we release it. But as I said, we need to look at each patient individually. And we generally cover with an antimicrobial dressing, because that way then we're going to reduce any infection or contamination of the wound. The next is healing by delayed primary intent. So this is where you need to autolytic debride the area. So here you can see it's a wound that's broken down. We've got a thick slough base of that wound. So autolytic debridement, you can choose products, your gels, your paste to assist in rehydrating this wound and lifting that slough away. Or you can use, and that way then when you get a good granulation bed, you can start to look at negative pressure wound therapy. Again, you've got to allow for that edema management, and the majority of these are a contaminated, not always infected wound. Again, we've got, being orthopaedics, we've got hardware directly under that slough base. So that's where we need to be very conservative in how quickly this slough lives. So some would opt to take this patient for surgical debridement, again depending on the comorbidities, or you would just allow that slow lift of that slough. Secondary intent. So this is where we leave the wound open and we allow it, and you can see here, to fill with granulation tissue. So this requires dressings which are suited to the size, the depth, the position, and the level of exudate. The wound itself should be clean. So the wound edges cannot be approximated, so that's why it's left open to begin filling with the granulation tissue. It's important when dressing these types of wounds to cleanse in the wound. Look at the wound irrigation. These wounds are a high risk of infection, so making sure that you cleanse the wound using, again, your normal saline, your Prontosands, your microdasins, depending on how the wound bed or how healthy the wound bed looks. When we're dressing these wounds, we've got to make sure that the dressings touch the base of this cavity, so that way then there's no dead space and no fluid can collect under the dressing. So again, if it's quite superficial, you can use your pastes or gels. If it's a little bit deeper, that's when you can use your hydrofibers and your alginates. You can also add a silver dressing if there's hardware close by to the cavity as well, just to try and apply the antimicrobial dressing and properties to keep this wound clean. These can be challenging because you can have a lot of exudate from these wounds. So that's where a lot of the challenge. So when dressing these wounds, you've got to make sure that you're looking after the surrounding skin and protecting it as well. So this might be where you could use barrier wipes or film dressings or hydrocolloid dressings just to protect that skin, and that'll stop further breakdown. With surgical wounds come complications as well. So you can have the hemorrhage, you can have hematoma formation, or you got a lot of bruising. You can have edema of the tissues, dehiscence. You can get necrosis secondary to the occlusion of blood supply, or evidently here you can get infection. So when we talk about dehiscence, this commonly occurs 5 to 8 days following the operation. It can be the absence of that healing ridge, so that induration either side of the surgical wound. More than half are associated with infection, so do consider taking a wound swab. So dehiscence is defined as a separation of the layers of a surgical wound. Sometimes it can be partial or might only be superficial, or there can be a complete disruption where the hardware can be on site. Some of the risk factors include overweight, increased or advanced age, poor nutrition, diabetes, and smokers. So again, with your wound management, it's cleaning this area. So this was a dehisced wound, and you can see the metalware on show. And this was the metalware was removed, and you can see how cleaner that wound's looking. So again, once the metalware is on show, especially in a wound, you're not going to be able to heal this wound due to there's no blood supply. So that way, by removing the hardware, that's your best chance of healing that wound. So cleaning the area lightly. For these types of wounds, we generally use negative pressure wound therapy. Some require washouts, as is the case in this example, especially when the hardware is visible. Superficial surgical site infections, they tend to occur within 30 days after the operative procedure. Generally involves the skin or the subcutaneous tissue of the incision, and your patients will usually present with at least one. So they may have purulent drainage from the incision. Wound swab might have an isolated organism. The patient will complain of a lot of pain along the area. You can get a lot of localized swelling, and you can see here the swelling and how much tension these sutures are under. You will see redness, and you can actually feel the heat. So it's always good to compare the other side as well. So again, the challenge of this is keeping the wound clean, using a quick cleansing, and also managing that exudate. Remembering to holistically look at the patient. So again, looking at what their nutrition, whether they need protein drinks, are their diabetes controlled, especially in the lower limbs, around ankle fractures, just seeing whether the patients do have deep vein thrombosis, because that can impact on their wound healing as well, especially for delayed ankle wound, surgical wounds, and keeping the pain under control for the patient as well. Infected wounds, we wouldn't put a dressing on that would stay on for a week. We would want to look at it a lot more regularly. Again, depending on the X-ray, how unwell the patient is, would determine how often you would actually have to view this wound. Here's another example of an infected wound, surgical wound site. Again, you can see the erythema. So this was a knee wound that got infected, just very superficial. So with this, we use negative pressure. Now, generally, I wouldn't put negative pressure over a sloughy area like this. But due to the exudate and the patient keeping the patient as an outpatient, we found the negative pressure worked really well for this patient. And this was an ankle wound, again, that became inflamed, diabetic patient, and you can see that sloughy, you can see the shiny, you can see the erythema, and you can see all this old eschar, the maceration from where a lot of exudate's been coming out of this wound. So again, cleaning up this area, removing not just this part of the slough, but looking at the whole skin and really preparing that peri-wound, which will assist with healing. Or you can have your deep incisional infections. These tend to occur within 30 days. If it's an implant, you can have up to 1 year. Tends to involve the deep soft tissue, the fascia and the muscle layers. You get purulent discharge. This is a dehyst. This was an elbow. You can see the tension band wire coming through. Again, your patients will be unwell. They'll have a fever, pain, very tender. Sometimes if the wound hasn't opened, you may actually be able to palpate an abscess as well. So again, looking at this wound will heal when this hardware or the metalware is removed, keeping this area clean, looking after all that surrounding skin, optimizing our patients' nutrition, making sure that we pick a dressing that our patients can move around and keep actively moving so we're not going to decondition them, and controlling that exudate. So again, once that hardware was removed, we used negative pressure. So the thing about negative pressure wound therapy now is we don't only use it for the dehyst or the open wounds, we can also use it for compromised suture lines. So sometimes we see our patients in the pre-admission setting, they are a high risk, they might be a diabetic, they might have a high BMI, cardiac failure, smoker. We tend to be able to identify that they are a high risk of that surgical site breaking down. So we tend to apply the negative pressure wound therapy. So some facilities will do the application in theatre, others may wait 1 day and then apply it. So then once we apply the negative pressure, we can leave that on for 5 to 7 days. Our patients can get up and keep moving. And then this was an example of a knee replacement, high BMI. After 5 days, you can see how well that suture line has healed. Also, the negative pressure will help take a lot of that edema from around the site. So normally with negative pressure, we're used to seeing a lot of fluid come from the knee, but in these circumstances, it's rare that any fluids come through. But it's a lot about that compression of the negative pressure to help with the fluid as well. And also in trauma patients, so here's an example of an ankle. So this was the first dressing review. So with this wound, we can see that, we've already got this ischemic area here. It's eschar, necrosis, a little bit of granulation in there, a lot of erythema along the surgical site. So sometimes with these wounds, it doesn't matter what we put on them. We know that it's going to break down. And some wounds may take a few days to actually declare itself, which it did here. So whilst we still maintained using silicone-based dressings on here, then once it got to here, we were able to start to slowly debride this slough area. And again, once this area had lifted, we could use either negative pressure or you could keep going with your silicone dressing. And this was the lateral side, which again you can see that's all very looking ischemic along here. We know that it's going to present itself, so we optimize, we try and keep this area clean, and then a couple of days later, this is how it presented. So that way, by using an antimicrobial over the top of this area, we're not going to introduce any new bacteria into the wound. Another unfortunate part that nurses come across are our pressure injuries. So it's good that the National Pressure Ulcer Advisory Panel and the European Pressure Ulcer Advisory Panel agreed on the pressure injury classification system. So this way we're all talking the same staging. So your stage 1, which is here, this is when you usually have intact skin and it's non-blanchable. So when you push down on that reddened area, it'll stay red. You may see a lot of this around the sacrum and the heels. This is when usually damage is done, but we need to offload. This is why our risk assessments with your Waterlows or your Norton or your Braden scores is important, especially for orthopaedic patients, to be able to offload that pressure. Your stage 2 pressure injury is your partial thickness of the dermis. It usually presents as a shallow open wound. It doesn't generally have slough associated with it, or that may present as a blister, especially around the heels. Then you move on to your stage 3. So this is your full thickness tissue loss. Generally, your subcutaneous may be visible, but bone, tendon, or muscles are not exposed. Slough generally is present, but does not obscure the depth of tissue loss. Sometimes this can include undermining and tunneling as well. And then you've got your stage 4, which is your full thickness tissue loss, and you usually can see exposed bone or tendon, muscle. Slough or eschar may be present on some parts of the wound bed, and the depth of the stage 4 pressure injury varies on the anatomical location, because on the bridge of the nose or the ear, because you do not have your subcutaneous tissue there, then a small area on a small break on your nose or ear could actually be a stage 4. And this is where you get a lot of device related, our patients on oxygen, or our intubated patients as well, or nasogastric tubes. You've also got your unstageable. So often these present as dark tissue. They're full thickness tissue loss in which the base is uncovered. Sorry, the base is covered. So that way then we don't know when this darker or hard eschar, when it lifts, how deep this injury will be. Or you've got your suspected deep tissue injury. So this is where you might get that pressure injury that can present like a bruise. So it can be purple or maroon, localized area. The skin's intact, or it could be a blood-filled blister. But again, it's going to take a while, or like a week to 2 weeks before this actually presents itself as to how deep this tissue is. And we're also doing a lot now in orthopedics around incontinence-associated dermatitis, which a lot of your stage 2 pressure injuries were incorrectly reported, whereas they were more of an incontinence associated. So these are the ones that present looking like they're skin tears. So I guess summary, always partner with the patient, making sure that they're aware of the management plans that we have for them. They're informed and they're collaborated with, especially with pressure injuries. So when they go home, we've got offloading techniques in place. If it's a surgical wound breakdown and we want to keep our patients in the community, then again, we're educating them and we're partnering with them. We want to optimize their nutrition We want to recognize symptoms early and offer good cleansing approach as well. So thank you.
Thanks, Megan. That was really interesting. You can hear me now? I just want to make sure.
Yeah.
Yep, cool. I just turned my microphone back on. I think it's a really interesting topic. Obviously, it's a really big part of orthopaedic nursing because we have surgical wounds galore and traumatic wounds and pressure ulcers and all sorts. I think sometimes people get a bit overwhelmed by, okay, I've got a wound in front of me. It's not standard. What do I do? I've got all these choices of dressings. What bloody one do I use? And there's so many different sorts. I don't really know. But going back to the principles you talked about, what are you trying to achieve? Doing that really good assessment of the wound is it'll tell you what sort of dressing to use. There might be a range of different brands of that sort, but you've got to understand what's happening with that wound and then address that with the appropriate dressing. But also, and you talked about this as well, is really important, is not just look at the wound. It's about the person, the situation they're in, hydration, nutrition, diabetes, all those other things are absolutely key as well. And you can dress the wound till the cows come home, but if those other things aren't optimized, you're not going to have a lot of success.
Yep, absolutely. And I think we underestimate the importance of cleaning the wounds.
Yeah.
Because if you get that right, then the dressing is, will just reinforce that good cleansing technique.
It's an interesting topic with eschar or a bit of slough. In the
Yeah.
past, we've sort of tried to use the appropriate dressings to lift that off over time. What are your
Yeah.
thoughts on doing manual debridement on the ward? If you've got the skills and to do that to sort of, I guess hurry that process up a little bit, you've got to be a bit careful, I guess. Is that something you
Yeah.
guys do, or people that do that?
Yeah,
Or
we do manual debridement a lot.
yeah,
Um, and just because to start to heal that up and to get a bit of blood supply and get that wound bleeding a little bit to really start that granulation process.
yeah.
So
I think
obviously
sometimes
we've
people are
been,
scared to start that.
yeah, and that's where we do courses in our facility where we
Yeah,
train people up to do it because obviously, especially when you talk about slough, if there's a tendon underneath, that's where it becomes quite a grey area for some people. So you've really got to know what you are cutting away at
it's
and what you are
that's
debriding.
really, really disastrous. The only other thing
Yes.
I was going to say was one of my colleagues. She did her PhD topic was on wounds that were left open. So many times. You get a call first thing in the morning. Can you take off Mrs. Smith's dressing? The plastics surgeons or the consultants coming around to look at the dressing. And you take the dressing down, you put a sterile towel over it, and 3 hours later they still haven't come around.
Yep.
She did some measurements in those situations around temperature and also
Yeah.
I think some moisture things, but also pH, and demonstrated that there was a really quite quick change in some of those factors that could have a negative impact on the wound healing just by, it makes sense when you say it, but, purely by leaving it open, waiting for some, person to come around and review it when, you could just take it off when they get there or take a photo of it next time you do the dressing instead. Those sort of things might be a better option.
Absolutely. And it's that humidity under the dressing that's helping with
Yeah.
the wound healing. And we're disrupting that and that's why, now with photography and everything, we're starting to advance and we've really moved away, but it does take a lot of education, especially for our medical colleagues to
Yeah.
start to
Yeah.
understand the principles of that wound management.
Yeah. And it's not okay to leave a wound open or and not
No.
dress for 3 hours. So
Yeah.
no, that's good. Well, that's part of what our responsibility is. So that's good. We can stand up and try and advocate for that. I guess that's really good.
Yep.
Excellent. Well, thank you very. Oh, and also the topic of blisters is that was really good. It was interesting because that's the never-ending discussion around what do you do with a blister? Do you leave it intact? Do you de-reef it? Do you drain it?
Yeah.
And like I said, there's
And I
no
think I should
straight
do a whole
answer.
presentation on pin site care as well.
Yeah, that's true. All right, excellent. Well, thank you very much for that. I'll put
All
this
right, no
recording up
problem.
on the ANZONA website. Well, we will get there in the next day or two. Yeah, thank you very much.
All right, thank you.